Alright, once again, good morning, ladies and gentlemen. I am pleased to welcome you all to our webinar on hemodialysis for critically ill patients with COVID-19. Today will be a fruitful day as we will be learning approaches in managing and caring for our COVID-confirmed hemodialysis patients. And before we go further, let us hear first a welcoming message from the L&D Manager, ICU Cluster Head, Ms. Jessica May D. Alabat.
It is with great pleasure and honor that I welcome you all to today's webinar entitled Hemodialysis for Critically Ill Patients with COVID-19. Warmest welcome to our nurses and to invited nurses from the different hospitals, Philippine Children's Medical Center, Dr. Joseph Abella Memorial Hospital, Regional Medical Center from Medical Center, of course, National Kidney at Zamboanga City Medical Center, Corazon Locsin and Bano Memorial Regional Hospital, Bacolod, Regional Medical Center, and Regional Medical Center. It is with deep appreciation that our guest speaker accommodated us to share her knowledge and expertise. She's a friend, a classmate in the Singapore Nursing Pedagogy Training. Hemodialysis is part of the treatment and management of our COVID-19 patients. And as the pandemic continues, we are faced with a multitude of responsibilities and challenges. The health system hinder us from opportunities to grow, learn, develop. It is the goal of PETD to provide our nursing staff with opportunity to learn from the best in our profession with topics that are very appropriate crisis we are facing right now. I sincerely hope that you will enjoy and learn from today's session. Thank you and maayong buntag sa tanan.
Alright, thank you so much, Ma'am George, for your warmest message. Now, without any further ado, let me introduce to you our resource speaker for today. She is a graduate of a Bachelor of Science in Nursing, a Master in Business Administration, major in Hospital and Healthcare Management at the Adventist University of the Philippines. She was an intensive care unit nurse for 8 years, a hemodialysis nurse for 6 years, a preceptor in competency development in hemodialysis, and currently the officer in charge, head nurse in hemodialysis unit at the National Kidney and Transplant Institute, Quezon City, Philippines. She was awarded as Best ICU Nurse Medical Residence Choice Award in December 2011. A DOH Certificate of Competence Level 3 in Renal Nursing Kidney Transplant in November 2012. And a DOH Certificate Competence Level 4 in Renal Nursing Hemodialysis in March 2016. A member in Philippine Nurses Association, Renal Nurses Association of the Philippines, Urology Nurses Association of the Philippines, and Critical Nurses Association of the Philippines. Ladies and gentlemen, help me welcome our resource speaker, Ms. Shyree D. Sarmiento, RN MBA.
Thank you for, I am humbled and honored to be your resource speaker today. I will be sharing with you my presentation. Thank you, Ma'am Jessica, for inviting me, and Dr. Maria Eleanor Concha, Chief Training Officer, Professional Education Training and Development Office, for inviting me to be your resource speaker today. Our NKTI Nursing Services Office is headed by our beloved Deputy Executive Director, Dr. Nerissa M. Hariel. She works with two hard-working department heads, Ms. Mercedita Hoxson, ROIC, for Critical and Special Care Department, and Ms. Maria Victoria Santos as OIC General Nursing Department Head. Our supervisor is headed by, our OIC supervisor is Ms. Elizabeth Espiritu, and my head nurse is Ms. Lalaine Presentacion. This is my hemodialysis family at NKTI. So today I will be sharing with you hemodialysis for critically ill patients with COVID-19. This will be the coverage of my presentation. First, I will be presenting with you the NKTI HD history and virtual tour, then statistics of critically ill who require dialysis, hemodialysis modalities for critically ill patients, strategies adopted during the pandemic, setting up dedicated hemodialysis machines at the intermediate care unit for COVID-19 patients, screening, patient and staff safety, infection control, endorsement, and lastly, the process flow for critically ill COVID-19 confirmed patients. First, please go to kahoot.it and enter the game PIN. Reminder, if you are one of the top 3 players by the end of the quiz, please send us a screenshot of your result for you to claim the prize, and we will contact you personally. Okay. So are you ready? You may join now. Can you see po? Substance in order to remove toxic substance in the blood. Okay. We'll proceed. We'll do this later na lang po. Okay, we'll proceed first to the NKTI HD history. We'll just do it later na lang po because we are having technical problem here. So, for the NKTI HD history, the National Kidney and Transplant Institute is known for advanced patient care provided by its medical and nursing staff, particularly in the treatment of renal disease, dialysis organ, and transplantation. Our hemodialysis unit provides care for a wide spectrum of patients from acute care inpatients to chronic care outpatients. With the latest state-of-the-art hemodialysis equipment, hemodialysis services for inpatients are available 24 hours a day, 7 days a week, except for hemodialysis annex for outpatient, which operates until or not later than 4 a.m. and start first session at 5:30 a.m. every day except Sundays. With double pass reverse osmosis water treatment, the water and producing ultra-pure dialysate for the HD of non-COVID and COVID confirmed facility. In 1985, hemodialysis main was opened with 16 stations and hospital bed for both private and service inpatients. After 20 years, our hemodialysis unit at Annex 2 building started to operate with 31 machines and 5 backup machines, open to serve for outpatient from Monday to Saturday. In October 2018, Hemodialysis Extension Unit for outpatient was inaugurated with 15 machines, 11 of which are negative machines, 2 Hep B positive and 2 Hep C positive machines. The current coronavirus, this is COVID-19 pandemic, represents a global challenge for citizens, health system, local and national governments. As of November 27, there is a 425,918 in total cases, of which there are 30,047 active cases, 387,616 recoveries, and mortality of 8,255 according to DOH.gov.ph tracker. Here is the weekly cases by the date of onset of illness in 4-week moving average. We see a decline from August to September in the trend, but it doesn't mean that COVID-19 is completely eradicated. This data show also that starting from August...
Excuse me, Ma'am Shai. Excuse
yes
me.
Po.
Paki-share,
Yes.
Hindi nakikita ang slides.
Oh, wait lang ma'am. Bakit kaya? Sorry. ...264 facilities reported, a total of 36.2% of bed occupancy as shown in the data occupancy rate level as classified. As per bed availability, focusing on the critical occupancy results, 39.75% or 754 of the 1,897 total of ICU bed capacity, 38.69% or 5,348 of the 13,000 total of isolation beds. Now let's focus on the ICU patient population as shown in the statistic. How will we continue on giving care despite the challenges we are facing this pandemic? In NKTI, we have but now 5 to 8 average number of COVID-19 confirmed patients dialyzed per day. But now the average is decreased to 1 to 2 patients. According to Hemodialysis International, renal patients appear at high risk for COVID-19 and related complications because most of them are old and have present multiple comorbidities, and some of them may use immunosuppressive drugs. So for the safe management of our vulnerable dialysis patients with confirmed COVID-19 infection in the critical HD units and safety of our healthcare workers, the administration of NKTI Hemodialysis Unit adopted and implemented some protocols derived from the Center for Disease Control and Prevention, with some modifications on the basis of the Infection Prevention Control Committee guidelines from our institution. So here are the strategies adopted during the pandemic. First, setting up dedicated hemodialysis machine in intermediate care unit, and then schedule for COVID-19 confirmed patients at hemodialysis main, prioritization and classification of patients for hemodialysis, suspect, probable COVID-19 confirmed. Provision of transport team and dedicated pathways for COVID-19 patients. Then physical distancing, decrease duration time as per doctor's order. Implement appropriate use of Another strategies are single-use dialyzer for COVID-19 confirmed patients, optimize the use of engineering controls and indoor air quality, and we have also skeletal workforce alternative work arrangement, training for all new HD nurses in hemodialysis in series with hemoperfusion, which is the preferred hemodialysis modality for COVID-19 patient. Manage visitor access and movement within the facility, environmental infection control, and limiting aerosol generating procedures. We have been using different HD modalities for critically ill patients, but not all were utilized because of the increasing number of COVID patients. Currently, we are using the dialogue hemodiafiltration, sustained low efficiency dialysis, ISO-UF capable machine of BPRON. We use sustained low efficiency dialysis as a renal in critically ill patients with acute kidney injury and hemodynamic instability. It is typically hemodialysis with a lower blood flow from 150 to 108. Dialysis flow settings is below 300 and a longer treatment time, 4 to 10 hours. Another mode of hemodialysis treatment that we use is the CRRT, or the continuous renal replacement. CRRT is a lower type of dialysis that puts less stress on the heart. Instead of doing it over the hours, CRRT is done 24 hours a day to slowly and continuously clean waste product and fluid from the patient. It requires special anticoagulation to keep the dialysis circuit from clotting. So we use Diapac po, and doctors and KT, I don't recommend this for COVID-19 confirmed patient because of the long duration time. So hemoperfusion, the most in demand HD modality is HD in series with hemoperfusion. The body of ICU patient with COVID-19 sepsis, MOS, or multi-organ failure, or systemic inflammatory response syndrome will cause inflammatory factors. They will increase mortality, hemoperfusion, and can also absorb these factors. It is a treatment technique in which large volume of the patient's blood are passed over an adsorbent substance in order to remove toxic substance from the blood. There are three major uses of hemoperfusion. First is to remove nephrotoxic drugs or poisons from the blood in emergency situations. Another one is to remove waste product from the blood of the patient with kidney disease. And lastly, to provide supportive treatment before and after transplantation for patients in liver failure. There are several types of cartridges. The HA230 acute poisoning, this is a cartridge for acute poisoning, acute drug, and toxin poisoning, especially the poisoning without the specific antidote. Another cartridge is the HA280 for immune disease, like dermatosis and psoriasis, pemphigus, chloasma, severe acne, severe drug rash, etc. The HA330 is the star for all season. The indications are sepsis, systemic inflammatory response syndrome, compensatory anti-inflammatory response syndrome, multiple organ dysfunction syndrome, multiple organ failure, and acute necrotic pancreatitis, multiple trauma crash syndrome. So what are the nurse responsibilities? First is to check for the doctor's order. So the nurse should check the duration. The duration should be not longer than 3 hours. 2 hours and 30 minutes, then 2 to 3 hours. The flow is 150 to 200, and the cartridge is the HA30. And the anticoagulation is heparin flashing or heparin priming and NSS. Also consider the checking of the access because remember is the lifeline of our patients undergoing hemoperfusion. So proper care and handling is very important. So if the access is AVG or AVF, check for the bruit and trill signs of infection. If you found signs and symptoms of infection, treat the doctors accordingly. For the central venous catheter, check the catheter should be in 2% chlorhexidine plus 7% alcohol, then allow it to dry. Hindi po ito pwedeng pipette. Okay? Nilagyan na ng alcohol, papayunan po. So, allow it to dry lang po. Then, catheter kept sterile before and after accessing it. Patients should wear a mask for all catheter procedures and gloves to be changed every procedure. Even before the outbreak of COVID-19 disease, we already have been doing hemoperfusion to critically ill patients. For patients with suspected or confirmed intermittent hemodialysis in the intensive care setting, dialysis should be performed in the patient's hospital room with the door closed. This serves to limit the patient's movement with the hospital. Please take note that the nurse cannot handle COVID negative and COVID positive at the same time. At the NKTI, our IMPU on the screen, or intermediate care unit and the hemodialysis unit are considered as hot zones. For COVID-confirmed critical ill patient, IMPU has 4 rooms, and each room has a dedicated HD machine for COVID-19 confirmed level 3 or level 4. Patients located level 3 and level 4 patients located at the second floor main hospital building with dedicated nephro fellow on duty 24 hours a day. HemoMain is our COVID positive, COVID suspect unit for both inpatients and OPD patients located in the second floor building with 16 stations po. Our intensive care unit has 8 beds, offers 24-hour comprehensive care to critically ill adult and pediatric patients classified as level 3 and level 4. ICU is not fitted with negative pressure rooms. Thus, COVID-confirmed patients are not admitted in the ICU. The nephrology fellow assigned to ICU and KT will see the patients only in the ICU. So they have dedicated Dr. Himpo. The screening for next is prioritization and classification of patients for hemodialysis. So all the screening for symptoms will not identify asymptomatic or pre-symptomatic individuals with COVID-19 infection. Symptom screening remains an important strategy to identify those who could have COVID-19. So appropriate precaution can be implemented. So in NKTI, patients for hemodialysis treatment shall be classified according to case. Clean case, COVID suspect, case with or without swab, or COVID case, they shall be further be classified according also to priority for treatment, priority A, B, or C. Patients with the same respiratory pathogen may be housed in the same room. For example, a patient with COVID-19 should not be housed in the same room as a patient with an undiagnosed respiratory infection caused by a different pathogen. Who are the priority A patients? According to According to CDC, the highest level of illness severity experienced by the patient at any point in their clinical course should be used when determining the duration of transmission phase precaution. So, the severe illness is individual who have respiratory frequency breath more than 30 per minute. And their SpO2 is less than 94% on room air at sea level. Or for patients with chronic hypoxemia, a decrease from baseline of more than 3%. Ratio of arterial partial pressure of oxygen to fraction of inspired oxygen less than 300 millimmercury, and lung infiltrates more than 50%. Critical illness individuals have respiratory failure, septic shock, and multiple organ failure. For the NKTI definition, priority A or critically ill patients, they have pH 7 less than pH 7.2, potassium is more than 6.5 with ECG changes, and bicarb less than 10, moderate to severe pulmonary congestion with pericarditis, severe uremia, hypotensive patients that need HD, poisoning, decreased deceased donor recipient needing HD. So, the HD nurse should perform the dialysis within 4 to 24 hours. Implement mechanism and policies that promote situational awareness for facility staff, including infection control, the healthcare epidemiology, facility leadership, occupational health, clinical laboratory, and frontline staff about patients with suspected or confirmed COVID-19 infection, and facility plans for response. So, healthcare, for physical distancing, healthcare delivery requires close physical contact between patients and healthcare worker. However, when possible, physical distancing, maintaining at least 6 feet between people is an important strategy to prevent SARS-CoV transmission. Example of how physical distancing can be implemented for patients include arranging seats. So we arrange seats in the dialysis cubicle so patients can sit at least 6 feet apart. We don't mix COVID positive and COVID negative even on separate cubicles. Nurse cannot handle also COVID negative and positive at the same time. We also designate areas and do staggered schedules for our healthcare worker to take breaks, eat, and drink that allow them to remain at least 6 feet apart from each other, especially when they must be unmasked. We reduce the hemodialysis treatment time from 4 hours to 3 hours during the COVID surge to cater all patients per doctor's order. We limit visitors to the facility to those essential for the patient's physical and medical needs. Example, medicines and consent. And patients watcher of COVID-confirmed patients are not allowed to enter the hot zone unless they present a clear chest X-ray result within 5 days prior to entrance. No visitors allowed in the hot zone because visitor might have underlying illness, putting them at higher risk for COVID-19. Give updates via cellular phone and provides instruction. But if relative need to enter in the hospital, such as do hand hygiene, limiting surfaces, touch, and use of PP according to currently facility policy while in the hospital. So, and we also instruct them that they should not go to other locations in the facility. Provides family meeting areas where all individuals can remain at least 6 feet apart from each other. Optimize the use of engineering controls to reduce or eliminate exposure by shielding our healthcare workers and other patients from infected individuals. Examples of engineering controls include the physical barriers and dedicated pathways for healthcare workers. So, as you can see on the left side is the entrance of all patients for hemodialysis at each domain, while the right side is the entryway for our healthcare workers. We improve also our indoor air quality in consultation with facility engineers, optimize air handling system. We also consider the addition of our portable solution, portable HEPA filtration to augment air quality in areas when permanent air handling system are not feasible option. According to CDC, some procedures performed on patients with suspected or confirmed SARS-CoV infection to generate infectious aerosol. So procedures that cause such as risk should be performed cautiously and avoided if possible. If performed, the following should occur. Here are the recommendations for aerosol generating procedure. Use of auto-face mask for patient. We use auto-face mask for patient having difficulty of breathing. Intubation should be in the airborne infection isolation rooms. Use an aerosol box during intubation. Anesthesia service is the only allowed doctor to do intubation with the use of CMAC laryngoscope to ensure safety during intubation. And suctioning using subglottic ET tube by attaching the line to wall suction or a syringe to remove contaminated oral secretions. We also don't do ambu bagging until patient is intubated. Instead, we use Ventipack for the ventilation of adults and our PEDSA patients. The number of healthcare present during the procedure are limited to only those essential for patient care and procedure support. We assign each team members a specific role during events of resuscitation. Implement use of personal protective equipment. Or according to CDC, employers should select appropriate PPE and provide it to healthcare practitioner or healthcare workers in accordance with OSHA PPE standard. Personal protective equipment, as defined by the Occupational Safety and Health Administration, is specialized clothing or equipment worn by an employee for protection against infectious materials, in which PPE does not remove the hazard but protects the wearer from potential contaminants or agents. That is why in the hierarchy of controls, PPE is the last line of defense. Universal precaution refers to the practice in medicine of avoiding contact with patients' bodily fluids by means of the wearing of non-porous articles, such as medical gloves, goggles, and face shield. The healthcare precaution started with the term universal precaution. It was in August 1987 that CDC recommended universal precaution in response to the HIV epidemic. This guideline stated that healthcare providers should consider blood and body fluid precaution for all patients regardless. And in 1996, the Center for Disease Control and Prevention established the term standard precaution. This broadened the focus on prevention, applying the principles to all patients regardless of diagnosis or presumed infection status. These guidelines also address below how we break the chain of infection. Healthcare workers should perform hand hygiene before and after all patient contact with potentially infectious material, and before putting on and after removing PPE, including gloves. Hand hygiene is particularly important to remove any pathogens that might have been transferred to bare hands during the removal process. So, healthcare workers should perform hand hygiene by using 60 to 95% alcohol or washing hands with soap and water for at least 20 seconds. Healthcare facilities should also ensure that hand hygiene supplies are readily available to all personnel in every care location. So let's keep our hands clean by keeping our nails short, no nail polish, no watches and rings, short lips is recommended, and we ensure that hand hygiene supplies are readily available. So gloves is used for touching blood, fluid secretion, contaminated items, for touching mucous membranes and non-intact skin. For gown, we use gown during procedures and patient care activities when contact of clothing exposed skin with bodily fluid, secretions, and excretion is anticipated. Mask and eye protection face shield during the procedures, and patient care activities likely to generate splashes or sprays of blood, body fluids, secretions, especially suctioning, and PT and intubation. During aerosol-generating procedures on patients with suspected or proven infection transmitted by respiratory aerosol, wear a fit tested 95 or higher respirator in addition to gloves, gown, and face eye protection. So like the other PPE, the selection of a respirator type must consider the nature of the exposure and risk involved. For example, N95 particulate respirator must be worn by personnel entering the room of a patient with infectious tuberculosis. So, however, if a bronchoscopy is performed on the patient, the healthcare provider might wear a higher level of respiratory protection, such as higher level respirator. That's why we also required our staff to have respirator or mask fit testing, and train them on how to safely put on and take off their PPE in collaboration with our IPCC nurse. Our administrator also provided toning and doffing area. These are the guidelines that our IPCC created on how to put on and take off our gear. So first, perform hand hygiene using hand sanitizer, and then put on isolation gown, tie all on the gown. Assistance may be needed by other healthcare personnel. Put on NIOSH approved N95 filtering face piece, respirator or higher. And if the respirator has a nose piece, it should be fitted to the nose with both hands, not bent or tilted. Do not pinch the nose piece with one hand. Respirator face mask should be extended under chin. Both your mouth and nose should be protected. Do not wear respirator mask under your chin or store in scrub pocket between patients. Here is here is our guidelines for doffing. First, we remove our gloves. Ensure glove removal does not cause additional contamination of hands. Gloves can be removed using more than one technique, glove in glove or bird beak. Remove gown and untie all ties or unsnap all buttons. Some gown ties can be broken rather than untied. Do so in gentle manner po. Avoiding a forceful movement, reach up to the healthcare personnel may now shoulders and careful pull down and away from the body. So rolling the gown down is an acceptable approach po. Dispose the used gown in a trash receptacle. Healthcare personnel may now exit after the disposal of the. There shall be a designated safety officer every shift to ensure that the safety protocol is observed by healthcare workers and other non-medical staff members when they enter the HD unit. Lead the safety briefing and at the beginning of each shift. So they will also guide the staff in the donning and doffing procedure and ascertain that there is no breach in the safety protocol and report as necessary safety issues encountered during the shift. Personnel entering the room should use appropriate PPE because we cannot fully eliminate the hazard, and we need PPE as part of the standard precaution as we are constantly exposed to these potential agents. So PPE number 1, based on the PPE ensemble, neck to ankle outfit, N95 respirator, hood, disposable face shield, breathable, high performance surgical gown, no zipper, boots, double long nitrate gloves. PPE number 2, head to ankle coverall, N95 respirator, hood with elasticated facial opening pero wala tayo nito dito. Disposable face shield, coverall covered by a plastic apron, boots, double long, nitrates glove. And PPE number 3, isolation gown for routine patient care and perform. Like these are the neck to ankle outfit and N95 respirator, no hood, disposable face shield, and water resistant isolation gown, no zipper and shoes, single latex gloves. Okay. The highest level A is the highest level of skin, eye, respiratory infection. So the indication is identified or suspected hazards. This is indicated to identify and suspected hazard requiring maximal skin, eye, and respiratory protection. For the level B, highest level of respiratory protection, lower level of skin protection. And for the level C, hazards will not be absorbed or adversely affect exposed to skin. This is the classification of the level 1 to 4 by ANSI AAMI. Water, minimal water resistance, some resistance to water spray. For level 2, lower water resistance, resistant to water spray, and some resistance to water penetration under constant contact with increasing pressure. And for level 3, moderate water resistance, resistant to water, and some resistance to water. And blood and viral penetration resistance. So another strategy that we adopted is limit transport and movement of the patient. So dedicated equipment should be used when caring for patients with suspected or confirmed as COVID infection. All non-dedicated, non-disposable medical equipment used for patient care should be clean and disinfected according to manufacturer's instruction and facility policies. We also encourage use of alternative mechanism for patient and visitor interaction, such as video call application on cell phones and or tablets. So we have provision of transport team. Our transport team are responsible to facilitate safe and prompt transport of patient from the emergency room to the main building, either for admission or for hemodialysis procedure. During transport, we use face shield or aerosol box, and patients should always use face mask to facilitate safe and prompt transport of patient from other units. For the another strategy for environmental infection control, routine cleaning and disinfection procedures are done every shift. Cleaning and disinfection also, and we do terminal cleaning of rooms on the last shift of the day. So we use environmental cleaning and disinfection intermediate and low disinfectant designed for environmental surfaces. So U.S. Environmental Protection Agency approved disinfectant. So special attention po to frequently touch item or surfaces likely to be contaminated by blood or body fluids. To help ensure patient safety, machine disinfection by chemothermal disinfectants. After each treatment, the system hydraulics must be disinfected with decalcifying disinfectant to remove calcification and microorganism. Otherwise, malfunction may occur depending on the concentrates used and bicarbonate concentration. Disinfection of the dialysis machine again after downtime 72 hours is recommended. Peracetic acid is also recommended with antimicrobial effect. So, do you want to have a break time or let's proceed na po to my next topic? Do you have question po? Hello? On our first shift po, unstable, clean, and cases lang po ang dinadialysis namin. And then followed by second shift, ito po yung mga COVID swab negative with pneumonia cases. Third shift, suspect or confirmed COVID cases. And the fourth shift is the COVID confirmed cases na po. So, the first step in our hemodialysis workflow is the nurse, the total patient care encodes complete hemodialysis orders such as priority A shall be priority level. For example, if the patient is critically ill and prioritized as A, they shall be dialyzed within 4 hours po. And other HD orders such as HD mode of treatment, duration, type of dialyzer or cartridge, ultrafiltration, blood flow rate, dialysate flow rate, anticoagulation, and other special orders like potassium to bath, blood transfusion, and etc. The next step is the charge nurse of the inpatient HD unit at HemoMain receives notification for hemodialysis, prints request form, and shall checks the printed HD notification for the completeness of doctor's hemodialysis prescription, type of payment, and cash basis ba ito or charge to bill, and priority level and other requirements to facilitate the procedure as follows. Then line up the chart according to priority level and polls total patient care nurse of ER or inpatient units to transport patient to the HD unit according to the DEC HD schedule with the requirements such as, but not limited to blood product, medicines, and tube feedings. So nurse in charge prepares the patient and gets the latest vital signs and brings the patient to the designated HD unit on time. So patient is directly sent to the designated HD unit. HD nurse and IMCO nurse shall facilitate the initial telephone endorsement and full endorsement at IMCO. During the endorsement po, the HD nurse checks for a valid informed consent and complete HD orders. Changes in the previous hemodialysis order, latest hepatitis test result, and other standing order, and pre-HD wait before hemodialysis commences. So, next is the HD nurse assess the patient takes vital signs, gets pre and post HD vital signs, evaluate and monitor patient's condition and management and care rendered until termination of HD. So once HD therapy completed, the HD nurse takes final vital signs and post HD wait and facilitate complete endorsement, which include post-HD wait, copy of HD treatment flow sheet, management care render documented at patient's chart with the IMCO nurse. All data entries are completed by the HD nurse in charge on treatment flow sheet that will be entered in patient database. The HD nurse or charge nurse shall encode data and charge patient's bill, and the HD staff reports as necessary safety issues encountered during the shift. The HD staff shall also do external cleaning of machines using disinfectant, yung meliseptol, dispose dialyzers, and all supplies used according to IPCC policy. Performs also external and internal disinfection of all equipment and machine, followed by UV light sterilization after every HD treatment. So all data entries is completed by the HD nurse, and so on the treatment flow sheet that will be entered into the patient database. And then so the HD staff shall do external cleaning of machines using disinfectant po. Nurses are no exemption. One success in the nursing profession is not determined by how much theoretical knowledge a nurse possesses, but how resilient you are to apply everything you've learned. And that includes the principle of caring. We are trained to care for strangers. However, there are times when our character is tested and we feel as though to do your job well has left us. God says in Proverbs 3:6, in everything you do, put God first, and He will direct you and crown your efforts with success. Thank you. So here are my references.
Okay.
There are a few questions here, Ma'am Shyree.
Yes, ma'am.
The first one is, how long does an HD nurse stay in the hot zones to provide hemodialysis treatment? Maybe this is about rotation?
Yes, ma'am. 4 to 6. We stay, yes, ma'am. 4 to 6 hours po. Actually, for our COVID patient, we dialyze them 3 hours. So, maximum na po yung 4 to 6 hours po.
Yung nurse ninyo, siguro ang ibig sabihin, I'm not so sure about the question, but yung nurse ninyo handling COVID patients, are they rotated to the non-COVID? Or talagang sa hot zone na lang sila until the end of the rotation? Meron ba kayong scheme from clean to, I don't think, I think ito yung kanyang question.
No, ma'am. Kailangan po yung hawak po ng negative, ay ng positive, doon lang po siya. Dedicated nurse lang po siya for the COVID positive po.
So there is no chance for them to be rotated to the clean zones, parang ganon. Walang like 2 weeks, 2 weeks, wala naman.
Ay, meron, ma'am. Ang ibig ko lang sabihin, ma'am, yung pag naka-duty na siya, di ba, 4 to 6 hours lang. And then, meron po kaming rotation, ma'am. Ma'am, every 2 months po, after 2 months sila sa hot zone, then punta na sila sa ano po,
Okay.
sa clean
So,
area.
Sa clean. Okay, 2 months and then swab and then transfer to clean. Swapping na naman sila ng
Yes, ma'am.
controls or considerations before you start the HP.
We don't start HP po kapag mababa yung platelet count po ng pasyente.
Okay. And then another question, is it safe to dialyze the patient in a non-COVID unit for COVID recovered patients who turned out positive later? Siguro ang patient, COVID recovered patient, dinialyze nila sa isang non-COVID unit. And then later, the patient turned out positive. I think ang tanong dito is, what do you do if the patient turns positive? When you dialyze the patient in a non-COVID?
Na nag-turn out to positive, ma'am.
Yes, ma'am.
Dadalhin po sila sa ano, ma'am, sa hot zone namin, doon sa dedicated unit namin for the COVID positive patient.
And then the unit, kung saan siya na-dialyze, ma'am, what happens to the unit and the people exposed in the unit if that patient turned out positive?
Okay. Kung saan po dadalhin?
Kung example, the patient, interpretation ko na to sa tanong niya, what if the patient that was dialyzed sa recovered patient, tapos doon siya dialysis sa isang non-COVID unit. And then
So anong gagawin?
Yes.
Anong gagawin dun sa patient na nag-turn positive?
Yes, ma'am.
So maka-quarantine po siya. Maka-quarantine po muna siya for 14 days.
And then yung area kung saan siya na-dialyze,
Yung area po, terminal cleaning po, and then double disinfection of machines.
Okay. I think wala ng questions. May tanong pa ba dyan? So that we can, our speaker can address your questions. In terms of effectivity, in COVID patients, is it more effective to perform HP plus HD? Or is it also effective if you only perform HP?
According to research po, ma'am, mas effective and efficient po yung HD plus HP po. And according also dun sa data, sa statistic namin po, most of our patients with COVID, most of our COVID patients na na-dialyzed HD plus HP are recovered po. We're able to recover po.
Okay, so thank you. Teka, wait. Wala nang questions? Yun na yung last question yata na nakita ko eh. Are there questions? Okay, so if there are no questions, I would like to thank everybody for the excellent participation to today's webinar and to our subject matter expert. Officially close this webinar by wishing you all good health, God's protection each and every day. God you all. Daghang salamat. Thank you so much, Ma'am Shai. Thank you to all our participants, to our
Thank you,
guests,
Ma'am
to our fellow
Jessica.
nurses. Thank you so much. Our next webinar will be on
Thank you.
December 10. Salamat, maraming salamat. Entitled Rising to the Challenge, the Emergency Nursing Response to COVID-19. Before we close, I would like to request Maurice to present the certificate of appreciation to our speaker.